My name is Jacqueline Akinyi, and in this session we are going to remind ourselves on how to respond to postpartum hemorrhage, bearing in mind that when you are in a team of rapid response, you have to be conversant with everything. You know, mothers can give birth in the community, beside the road, you know, when they are traveling, or when they are just walking, or on their way to the hospital for clinic checks. So you don't know when it will happen. So a mother can deliver anywhere. So you should know how to respond to postpartum hemorrhage in the event that occurs. So it doesn't happen always in a hospital setup. It can get you anywhere. So to start us off, I'll just remind us that at the end of this session, you should leave this place knowing how to prevent PPH, how to detect it, because it's very key. You have to detect PPH and you have to respond. So first, you have to prevent it, because you don't have to wait for it for you to act, prevent it. Because anyone giving birth, you anticipate PPH, okay? Then detect it. Is this mother having a PPH? And then you respond accordingly, okay? So I would like one of us to give us a definition of PPH and how you understand it. Kennedy?
PH, I would say it is bleeding following delivery more than 500 minutes to talk about spontaneous, and more than 1,000 minutes to talk about cesarean.
Good. In addition to that definition, please turn your tag so that I can get you. Okay. Caroline, in addition to what you have said, how else can you define postpartum hemorrhage?
Excessive bleeding of a mother.
Excessive bleeding of a mother post-delivery. So other than quantifying, you can also look out for the symptoms. Because it can be just that 200, but the mother is symptomatic. You know? Probably they were anemic before, and then they've bled 300 ml. They are having symptoms already. Okay? So don't just stick to the amount, the symptoms. Okay? And then how do we classify PPH? Samuel? Classification? Pass. Okay? Who can classify PPH for us? Whereby primary is within 24 hours, and secondary?
Up to 6 weeks.
To 6 weeks. Huh? So the 6 weeks aspect has changed. It has now moved to 6 months. So if a mother comes to you at 6 months bleeding, don't say that is normal menses. Please check. Just check. Huh? Don't assume. That is normal menses. So it has changed. It's no longer 6 weeks as it used to be before. So up to 6 months when they come to you, please just respond. Assess the mother and respond accordingly. Okay? Okay. So I said we are going to prevent, detect, and respond. Okay? So how do we prevent PPH? Prevention? Sylvia?
You ensure that post-delivery you have expelled all of your clots, you have inspected the status of the cervix.
Okay, you expel the clots. Something else? Grace?
You also give syntocin after delivery of the
Give oxytocin, okay?
Maybe if you can look at this manner in terms of prevention, talk about antenatal during, that is during the delivery and then postnatal. So if you can talk about antenatal, just optimize antenatal care.
Okay.
Check out our HB supplement.
Okay.
Then during, now talk about the use of oxytocin.
Very good. So you categorize it. You can attack it at antenatal period. If a mother is anemic, correct the anemia. There is factors that is. Mother is anemic. If the mother is carrying twins, please advise them to come and deliver the hospital. They are high risk at that moment. If the mother is having infection, they are having hypertension, you have to prepare them early enough, okay? So antenatally, if their HB is low, you have to correct that before they go into labor, okay? Sawa. So antenatally, we've attacked that. Intranatally, like during delivery, we've said you're giving an oxytocin, but they usually are sequence to that. Active management of third stage of labor, okay? So once the baby is out, first thing first, the moment you deliver the anterior shoulder, you are going to give oxytocin. 10 international units IM. That is preventive. You're giving IM. Or if that one had not been done, after the baby has been delivered, you give 10 international units IM, okay? Then after oxytocin, what you're going to do next is controlled cord traction. After you've seen signs of cord separation, there'll be that gush of blood, the fundal height recess, okay? A lengthening of the cord. So you check for signs of placenta separation, then you do continuous controlled cord traction. And how we do that is usually you have your cord is out here, I know how our baby is. So don't do this, we don't open the abdomen. So I'm assuming this is my cord, okay? And it has lengthened, okay? You've seen a gush of blood. So how we do, you don't just apply traction on it. If you have a forceps, you roll it on a forceps, okay? The forceps that you are using, okay? So you roll it on a forceps. Then you are an dominant hand. You're going to do a Brandt maneuver. Brandt maneuver, like this. You don't do this. So Brandt maneuver, like you are preventing the uterus from inversing as the placenta comes out. So Brandt maneuver as you are pulling the cord downwards slowly. Sorry, so it can do that. It can cut if you apply a lot of force. That happens. It happens, okay? So to avoid that, you have to be gentle, continuous, controlled cord traction. So you come in out slowly until it's out completely, and then you are going to examine it for completeness. You have to make sure there's no cotyledon that has been left inside or the membranes are intact, okay? So active management of third stage of labor, you've delivered the placenta, and then next examining it, or you give your assistant to examine it. At that point now, once the placenta is out, you're going to do uterine massage, okay? You are at the right side of the or is it becoming drowsy, you have to intervene. RBS check, do we do that? The mother has delivered, assumption is that amekuwa tu sawa. The mother was a client, haiwezi kuwa imeshuka. Could be they've not ate for 2 days. No, our mothers usually forget, they don't want to mess the situation. We've realized that they starve for 2 days. They're just taking liquids. So you have to make sure your D is corrected, okay? Then at E, what are you going to do at E? Exposure. In exposure, what are you going to do? Head to toe examination. Then something else? Warmth. That's something we usually forget. We've exposed the mother is shivering. You've given your misoprostol, it causes shivers. They shiver so much. Usually after delivery, mothers start shivering. So you have to make sure they are warm as well, and plus they are bleeding, okay? Yeah.
Don't also forget to assess the pupils.
Yeah, at D you have to assess the pupils, okay? So if the pupils, how do you want them to look like? For the pupils? Equally. And if one is reacting to light and the other one is dilated? Anisocoria. If they're having anisocoria? Brain injury. Could be they had a CVA at some point which did not correct, okay? Yeah, so sawa. So to put that one into practice, we are going to do a scenario and have it done here. You know, singing is easy and performing is different, okay? Now, Shalom will be the team leader. I want you to have a team, assuming that you are in a rapid response team. prepare your members. Then I give you a scenario so that we now put it in action. Quick one. Then, so if you're going to team play, you have to move forward. This baby will not get out. So assemble your team by names, and then you maintain the closed loop.
George.
Yes.
Okay, George, you'll be in charge of airway.
Closed loop.
You accept the name?
Closed loop. Let's try to repeat whatever the instruction she's giving, repeat it back so that we close the loop.
So George will be in charge of the airway. So you'll be in charge of
I will be in charge of airway. I'll be in charge of airway.
Sam will be in charge of circulation.
I'll be in charge of circulation.
Grace will be in charge of documentation.
I'll be in charge of documentation.
Sylvia will be in charge of drugs.
I'll be in charge of
Circulation is drugs.
So once you accept your role, you move to, so that we move, you move to where you are. If it is drugs, you go where drugs are. Okay. Take your position.
in charge of drugs, yeah?
Circulation and drugs.
Okay.
Airway.
Niko kwa airway.
You're in charge
Can use this one.
Airway.
Okay, so
The defibrillator.
defibrillator is on the way. Someone has gone for it.
Gloria
Okay.
will be in charge of the defibrillator. Do you accept the
Okay. Are you ready?
Yes, you
Okay, so I'll give you a case, and then you run it, okay? So you've just reported in the morning for a shift, and then you get a phone call to labor ward. And they're informing you that a 39-year-old woman in her first pregnancy delivered twin sons 2 hours ago. A vaginal delivery was planned and she went into spontaneous labor at 38 weeks and 4 days. Due to decelerations in the cardiotocograph for the first twin, both babies were delivered by ventus after 30 minutes active pushing in the second stage. So the lochia has been heavy since delivery, but the woman is now bleeding heavily and passing large clots of blood. On arrival in the room, you find that the sheets are soaked with blood, and there is also approximately 500 ml of blood clot in a kidney dish on the bed. Proceed.
First thing, I will show my safety and the safety of the patient. Then after that, I assess my air. Then, is the mother conscious?
Yes, she's conscious but drowsy.
Okay. She's called what?
M, Mrs. M.
Mrs. M.
Yes.
M?
Yes.
Okay. So my airway is patent. Then I'll check for breathing.
So when you're assessing breathing, RR is at 23, and respiratory rate is at, SpO2 is at 92.
92. That isn't bad. And then I'll go to circulation. I'll supplement oxygen. First thing,
I'm the one doing it.
ngoja niwape instruction. So,
I'm position the kitchen.
Okay. Your patient is on the monitor.
so we have a mother here who has recently delivered twins. So I need your help. Come in the delivery room. Okay. So, George,
Yes.
there is patent.
So that's no issue.
Breathing.
The oxygen.
Okay, put the mother on oxygen. 2 liters via nasal prongs.
So
Okay. So that one is being fixed.
from time here.
So I'll go to circulation. Circulation, connect the mother to the cardiac monitor and check the vital signs.
So I'll
First,
check,
wait. Okay,
I'll
connect.
check for the capillary fill, whether the patient is anemic.
So the patient is pale.
Put our 2 large bore cannulas,
I fix them.
then take blood samples
Which samples do you want taken?
for complete blood count, for clotting factors, XM,
Okay.
better, and UCs, and RBS. So how are my vitals?
Carry on the monitor.
SpO2 still 92.
Yes, SpO2 is at 92, heart rate of 112, BP of 120/80, echo of 5.2, and respiratory rate of 23. We are still doing 23. Respirations have not improved.
So we need to, the mother is tachycardic,
Yeah.
so it means she's compensating. So the SpO2 is at 92.
92, yeah.
Can you increase
Increase the
oxygen
oxygen.
to 6 liters?
All right, so we put a simple face mask, and then we've increased the oxygen to 6 liters.
Okay, that one has been done.
Yeah. So after that, I'm going to assess the,
We have a heart rate of 112. Is there anything you want to do at that point? We had our 2 large bore cannulas.
so we
And the
need
mother is
to
breathing.
fix fluids as we are waiting for blood.
Go ahead.
So
So you can give whole blood as wait for GXM.
So whole blood is not yet here.
So give the patient 1 liter of fluids.
Check your current monitor.
The blood pressure is going to 90.
The,
Heart rate of 112.
so first we are going to assess the cause, because the BPs are going down, meaning the mother is bleeding. So we are going to assess. We are going to remove if there are any clots as she is bleeding.
So on assessment, you find that the mother is profusely bleeding, and she has a tear, 2nd-degree tear, which was sutured. But she's profusely bleeding, so you can't continue with the assessment.
The tear was sutured.
It was sutured. It's repaired, but she's bleeding.
So we are going to give drugs, oxytocin.
Before drugs.
For the floor.
So assess the uterus.
So I'm going to assess the uterus.
It is soft and boggy,
So
and it's at the umbilicus.
yeah?
Soft and boggy, and it's at the level of the umbilicus. Soft and boggy, and at the level of the umbilicus.
I'm going to massage it
You massage the uterus
as I
as you check. Massage the uterus.
Then
Okay.
after massaging,
So as you're massaging, there are clots coming out.
yeah. I remove the clothes. Then I reassess the mother.
So the mother is deteriorating. She's now not responding to you, but she's breathing, and there's a pulse.
She has a pulse.
Yeah.
132.
She's just deteriorating.
51.
So the blood, is it ready?
So blood is being prepared.
So
Is she still bleeding?
The mother is bleeding, and the uterus is still boggy.
So we are going to give oxytocin, and then we do
Give instructions. Someone was on.
so our mother is still bleeding, and we have. I think we need to do a.
Before then,
Give oxytocin.
Give oxytocin.
Yeah, you can give the drugs now.
how much oxytocin are you giving?
40 international units.
Clear instructions.
So give oxytocin 40 international units in 1 liter of normal saline.
So that one is done. What else?
So I'm going to catheterize the mother. If there is a full bladder.
Give
So,
instruction.
calculation. Samuel, can you categorize the mother?
So as he's looking for the catheter, he's
Oh, yes.
Bacteria or SpO2 is going down and the BP is also dropping.
Oh, so we need to, Cynthia.
So we have to increase.
So you're going to use an air rebreather
Yeah.
and put the mother to oxygen.
Okay, I'll
Okay.
put the mother on oxygen. Can we give some now?
Yes, give
how much?
1 gram IV.
Hmm.
Samuel,
So tranexamic is being sourced. What else do you want done to this mother? The oxytocin is over.
give Cytotec.
To your
Samuel,
tube.
give the mother Cytotec parental at 600 micrograms. Yeah. So Cytotec at
20 minutes later, the mother is still bleeding profusely, and the vital signs are worsening.
We put our UBT. Can we put our UBT?
We need to escalate the health now.
I think we need to use a uterine tamponade.
We need to escalate the call for help.
So they are preparing for uterine tamponade. What else can you be doing?
We continue transfusing. The heart rate is at 154.
And the mother is bleeding profusely.
So we are, they said,
So he's still looking for the condom. What can you be doing in the meantime?
Did the uterus contract?
Not yet contracted. The massage was done. The uterus is still boggy.
We need to raise an alarm again.
Call is underway. They're coming.
The blood?
Blood is here.
so someone connects the blood to the patient.
Okay, so blood is being given. What else can you be doing in the meantime?
They assess the
So the mother is still deteriorating.
Check the patient with you.
Okay.
before
Before theater?
oh my god.
I'm improved. I'm improved, actually.
Okay. Let's stop there.
But saturation is still low.
We need to take the mother to the
Let's stop there.
Tell them about UBT.
Okay. Oh, hawajafanya BUBT. Okay.
From all health, prepare theater, and then we go on the
Yeah. So before theater, before wheeling this patient to theater, she suggested UBT. Yeah. You put the UBT. We will learn that one in another skill station. So you put in the UBT. Or we do it conclusively. You put the UBT. You will be shown how to do it, and you leave it in until definitive care has been implemented. Okay. Sawa. Let's assess the case. How was it? How did you find it?
So for me and my group, the scenario was good, but it was challenging. So and it was not flowing your care. There's some confusion here and there. So despite giving medication, giving various intervention, but the mother was still bleeding.
Is that what happens in the real situation?
Yes.
Yes, so it was not complex because you responded accordingly. Yeah. It's only that you needed to go through everything. Okay, what else?
Team members.
Team members.
Sometimes she wasn't listening. She was thinking by herself. Sasa hasikizi vile tunasema.
Yeah, knowledge sharing. You didn't utilize your group well. Yeah.
From the members who are
There's a member who was not utilized. Wasted resources. Yeah. So the positives,
Mwambie keep mother warm.
positive ones, at least you are the positives first. Gloria, anything positive? The mother was saved. Anything else?
Well, as much as she says there was no flow to it, I feel like there was flow.
There was flow.
Yeah, you knew what you were doing, just that ile ulikuwa unaona ni kama unachanganyikiwa, lakini you knew what you were supposed to do. Yeah.
True. Gloria?
I think we did well. There was some of the items they were here, they were already arranged at the scenario. So when an item was needed, it was readily available.
So in the real situation, you've been called. No, you were not there. So you didn't prepare the setting. You are calling. You're in labor or you work in the emergency department. You're here asking them, catheter. Someone tells you pack a store. Yeah. So it happens.
Yes.
So you should anticipate that and know what can I be doing in the meantime. Okay. So it's expected. So the other thing.
And also, when you call for help, it is advisable you mention what you need them to come with, like help. I have a mother with PPH, come with PPH box. So, because when they come with your PPH box, you expect those things that you need are also inside the PPH box. So. Then next, remember the 40s. Remember the 40s? The tone, tear, nini? And thrombo.
Thrombin.
So, did you give tranexamic acid?
Yes.
Okay. So remember the 40s. Then remember, however much you are dealing with PPH, systematic approach still applies. So when you follow the systematic approach, everything will just go. When assigning the roles, give them clear roles. If you tell George to be at the airway, what do you expect George to be doing at the airway? Maybe he doesn't know what I'll be doing at the airway. When at circulation, get in with 2 large bore cannulas and anticubital fossa. At the same time, come up with samples. This is a PPH. We need to have started. We have started IV fluids as we wait for blood. So, we normally say we don't bleed IV fluids. Do you bleed on saline?
No.
So we anticipate to get at blood as soon as possible. Then the rest follow. Now we are at UBT. We'll go to do the EPT later.
Okay.
Remember, anytime you want a patient to be dynamically unstable, it's important to monitor your urine output. Very important, because if you're not having urine output, you'll just be going down. So that is something that's very important to monitor. And then also the presence, availability of blood group O negative.
Very important.
Very important. Sometimes you will not waste time waiting for a post-match when you have a non-negative, you can just get the O negative and run it.
Okay. So just to remind us is that not all the time you'll get your lab works ready. If your lab is not in a position to do coagulation panel, you can do a bedside clotting time. Yeah. So as you're drawing your samples for grouping and cross-match, leave one in a red top or in a syringe, 10 to 20 minutes. Check if it has clotted, because you can be you could be thinking that I'm dealing with tone issue, yet it is thrombin. Because you didn't get the previous history of the patient, past medical history, you don't know whether they're on warfarin, they've been on heparin, or they took aspirin. So, you just came when they're already in that state of bleeding. So you didn't remember, like in your case, you didn't ask me past medical history. So you didn't remember. Probably it is a thrombin issue. They're having a coagulopathy. So you can do it at that time, okay? And then now in tears, some tears cannot be repaired. Could be you are looking at the perineal tear, yet they had another tear. Could be it's cervical tear. Because the patient was bleeding, you could not continue with your assessment. So it's something that has to be repaired in theater. So you anticipate all that. As you are working, you are already thinking, what else, what differentials can there be? Okay, so there are those times when your patient can really bleed more than 1,500 ml, 2,000 mils. So at that point, what do you activate? You only have 1 pint of whole blood that has arrived. So what are you going to activate? Tim? Patient was bled. Patient has not gone to theater yet, but they've really bled. Massive. Massive transfusion protocol. So when you are activating your massive transfusion protocol, what are your instructions? Because if you're sending Sylvia to go get blood, what instruction are you going to give Sylvia? What ratios? Because if you have the components of blood, your facility has them. So how can you ask for them? Tim, how are you going to give the ratios?
What is that? The massive
Transfusion protocol.
We're doing 211.
211 in PPH or in trauma? In trauma. Okay. So trauma is a bit different from PPH. So in PPH, the current guideline is you do a 6-4-1. 6 is the red blood cells, the packed red blood cells. 4 is the FFPs, and then 1 is the platelet. So platelet is 1 in all. You can use a 6-4-1 or a 4-4-1. So 4 pints of packed red blood cells, 4 pints of FFPs, and 1 pint of platelet, or 6-4-1. So you can settle on either. So for PPH. So for trauma is usually 1-1-1. So if you're giving 6 pints, it has to be 6-6-6. Okay. 6 of packed red blood cells, 6 of FFP, and platelets. Just it's 1-1-1. 6-4-1 or 4-4-1. That is as per the advanced obstetric life support. Yeah. Okay. Any other input?
Just an addition.
Yeah.
In terms of first aid for PPH. In Bungoma, I work in Bungoma, in ICU and also in the emergency department sometimes. First aid approach to PPH. If you can't access your UBT initially, there is a very nice device that we normally use in Bungoma. We call the non-pneumatic shock gamuts. Don't know how many have used it, and you have used it. How was the outcome? It works, okay? If you can optimize the use of that device, it can really help to minimize bleeding, because ideally just offering external compression to the lower limbs and also to the uterus before maybe you access definitive treatment. So it can really be a life-saving skill if maybe you are at Mashinani and you are basically referring this patient to a county referral hospital. You can't maybe do your UBT, but you can access your pneumatic anti-shock garment. That can be life-saving, right? Yeah.
So, 1 minute before we continue with the discussion of that. Our training is really based on what is locally available, because NASG might not be available for everyone who is in this hospital, but everyone in the any facility has a catheter, a condom, and a suture and cord clamps. True. Yeah. So UBT is good. NASG is really good if it's available. But the whole training is about, first of all, getting to have the locally available techniques of using the locally available resources, and then if we have the advanced one, the better. Senior, we get there. But that shouldn't stop us from giving the best care we can give to a patient. Going back to our objective, which is PPH, yes. What we saw with this patient, they were still bleeding and they were asking what else can we do. So there's something called bimanual compression. Okay, so you compress the uterus and then you put your fist in to the vagina and bimanually compress the uterus. That can be held in place as you wait to prepare UBT. Once the UBT is prepared, it can be inserted, and then the bleeding can stop. Okay. So another option is also giving abdominal trauma, just one. You compress the abdominal aorta by going deep into the stomach of the patient while feeling the femoral pulse until it disappears. That way you're compressing the aorta and stopping the bleeding, the flow of blood to the uterus as you prepare for the UBT. That allows for access of the vagina. If I put my hand in, you can't access to put the UBT. But if I have done the abdominal compression, you can put the UBT, okay? So that's what we were looking for, the bimanual compression, and then you can insert the UBT. So as we go through our objectives for today, first of all, we talked about definitely preventing PPH from occurring by active management of stage 3. Then we talked about early detection, and there are ways that have been brought forward for early detection, and we have like emotive, have that garment to tie on the patient, such that you're able to estimate accurately the amount of blood you have lost. Because when you use your eyes, it's very hard to judge the amount of blood loss. I can estimate some blood loss as 500, someone else will say 200, another person will say 600. True? It's not accurate. But if we have a measure that is standard for everybody, it helps us with early detection. So once you detect that we have PPH, there's a structure to follow. As we said, in emergency, we always use we use our algorithms that helps us not miss any step. Okay, so you call for help, as you can see from the top there. You call for help. Once the people come, you assign roles and you start making sure that the ABCs of the patients are stable. Usually bleeding will be at C. That's why we have said ABC. So airway is safe. Breathing is adequate, you go to C. C, and on top of fixing the lines, now you come to the uterus of the patient. You massage the uterus, you empty the bladder, and then now you can start giving the drugs as you examine the patient for tissues, for tears and tissues. Okay. Also, remember to examine the placenta for completeness on the side. Okay. As you're examining for tissues inside the patient, also examine the placenta. Okay. And then repair any issues, any tears that we see. Misoprostol, as we said, tranexamic acid, oxytocin, and then you do the bimanual compression or abdominal compression. Put the UBT as you wait for definitive treatment. UBT is not a treatment; it's a control measure for bleeding until you can get definitive treatment, which is going to theater maybe for B-Lynch, maybe for hysterectomy or ligation of the arteries, okay? So also remember to do a bedside clotting time. So, see, those are the objectives for PPH. If we follow that, we make sure that we don't miss any part of the management of PPH, and we actually know what we're doing and we're saving our patients, okay? So, for now, use the locally available resources as much as possible, but agitate for those. NASG is really good. So, agitate and tell your people to buy it in bulk or
just 1,000.
Yeah.
You can budget in the facilities.
Any questions? Any questions? Questions?
20 minutes.
Sawa. Okay. Sawa sawa. Thank you.